Hello dear doctors, very good evening. Welcome to the today's session on high-yield MCQ for INI-CET 2023. So here there are few set of very high-yield questions which were taken from previous year INI-CET papers and few clinical scenario questions. Okay, so the first question I want to discuss today is modified biophysical profile. Okay, so now dear doctors, this was a repeat question which was asked in the previous year. Yes, sir. In the November INI-CET 2022, the question was asked. So, two questions on biophysical profile in previous year. So, that's why I took this question. So, modified biophysical profile includes, what is the answer for this question? I'm waiting for the answer. So, modified biophysical profile includes NST plus gross fetal body movements, NST plus fetal tone, NST plus amniotic fluid index, NST plus fetal breathing movements. What's the answer for this question, dear doctors? So, I'm waiting for the answers from you all. So, what is the answer? So, modified biophysical profile includes, it is NST plus amniotic fluid index. Please make a note of it. NST plus amniotic fluid index. Dear doctors, you should know what is this biophysical profile. Please make a note of it. What is this biophysical profile? That is BPP. It has got 5 components. So it has got 5 components. So that is, one is fetal tone. Please make a note of it. Fetal tone. Fetal breathing movements. Fetal breathing movements. Yes. Then gross body movements. Gross body movements. Gross body movements. Then single deepest pocket. It is not the amniotic fluid index. It is a single deepest pocket. Single deepest pocket, SDP, which is also called as maximum vertical pocket. Then non-stress test. Non-stress test. So NST. So these are all the 5 components of biophysical profile. Each component will be given a score. Doctor, each component will be given a score of 2. You got the point, doctor? Each component will be given a score of how much? 2. So, now doctors, so maximum score is 10 by 10. Maximum score is 10 by 10. You got the point of this? Are the 5 components of biophysical profile. Now, what is this modified biophysical profile? This was a question in previous year INI-CET. Modified biophysical profile. It has got only 2 components. One is NST plus amniotic fluid index. Please make a note of it. One is NST plus amniotic fluid index. That is AFI. Understood, doctors? So, I think most of them know what is the single deepest pocket and amniotic fluid index. Doctor, amniotic fluid index is some of the 4 components, some of the 4 quadrants. Understood, no? That is vertical dimension of largest pocket not containing cord structures in all the 4 quadrants is measured and will adding up. That will gives what? Amniotic fluid index. But what is the single deepest pocket? That is vertical dimension of largest pocket not containing cord structures or fetal extremity in any one pocket. In any one quadrant is measured. So all the 4 quadrants is amniotic fluid index. In any one quadrant is single deepest pocket. I think this is clear, doctors? Yes? Yes. Now with this we will proceed to the next question. Now, which of the following statements regarding uterine activity is false? Yes, this is once again repeat question from previous year. So which of the following statement regarding uterine activity is false? Now look into this. Contraction of the uterus occurs in a coordinated manner due to polarity. What is this polarity, doctor? Polarity is nothing but upper segment contracts, lower segment relaxes. You should understand. What is this polarity, doctor? Upper segment contracts, lower segment relaxes. Okay, so now that is called as polarity. Now intensity of the contraction decreases from upper segment to lower segment. Intensity of contraction decreases from upper segment to lower segment. Okay, so this is a polarity. So contraction of the uterus occurs in a coordinated manner due to polarity. Intensity of adequate uterine contraction is about 200 to 225 Montevideo units. Unique property of retraction is associated with cervical effacement. Left corner of uterus serves as a predominant pacemaker of uterine contraction. What is the answer for this question, dear doctors? Dear doctors, what is the answer for this question? I am waiting for the answers from you all. Even if it is wrong, please tell me what is the answer for this question. So, I am waiting for your answers. Which of the following statement regarding uterine activity is false? I told you contraction of the uterus occurs in a coordinated manner due to polarity. Yes, definitely it is a true statement. I told you what is polarity. Upper segment contracts, lower segment relaxes. So as contraction spreads from upper segment to lower segment, intensity decreases. Intensity of uterine contraction decreases. What is it called as? Polarity. Now intensity of uterine contraction is about 200 to 225 Montevideo units. Yes, once again it is a true statement. True statement. So most of them are answering option C. So this question is, which of the following statement is false? Now unique property of retraction is associated with cervical effacement. Definitely it's a true statement. Definitely it's a true statement. And left corner of uterus serves as a predominant pacemaker of uterine contraction. It is a false statement. Now doctor, in this session I want to tell you what is this retraction. Doctor, look into this. So what is a pacemaker of uterine contraction? Dear doctors, what is a pacemaker of uterine contraction? That is cornua of uterus. Please make a note of it. Cornua, dear doctors, cornua of uterus is a pacemaker. Is a pacemaker. That too, right cornua. Dear doctors, right cornua is a predominant pacemaker compared to left cornua. Left cornua. And you all know the upper segment contracts. Dear doctor, upper segment contracts, lower segment relaxes. What is this called as? Polarity. Now doctor, so the muscle fiber at the end of the relaxation, muscle fiber will shortens. You got the point, doctor? You should understand. So muscle fiber will shortens. Once the muscle fiber shortens, it won't come back to original position even after the contraction is over. You got the point, doctor? Once the muscle fiber shortens, it won't come back to the original position once the contraction is over. That is, permanent shortening of the muscle fiber is nothing but retraction. Please make a note of it. What is this retraction, doctor? It is permanent shortening of muscle fibers. Permanent shortening of muscle fiber. So now doctor, look into this. I was telling you, upper segment contracts, lower segment relaxes. Upper segment contracts, lower segment relaxes. When upper segment contracts and lower segment relaxes, so cervix will become a part of lower uterine segment. You got the point, doctor? Cervix will become a part of lower uterine segment. Means lower uterine segment will start taking up the cervix. Means cervix will start dilating or will start effacing. You got the point? What is that property called as? Retraction. Means at the end of the relaxation, the muscle fibers shortens. When muscle fibers shortens, please make a note of it. When muscle fibers shortens, dear doctors, so now the lower uterine segment, what happens? Lower uterine segment will start taking up the cervix. And means cervix will become a part of lower uterine segment. So now, due to retraction, please make a note of it. Due to retraction, dear doctors, retraction is a unique property of a Now doctor, due to retraction, yes, it leads to lower uterine segment formation. It leads to lower uterine segment formation. It leads to cervix dilatation and effacement. Cervix dilatation and effacement. And it also leads to progressive descent of presenting part. Progressive descent of presenting part leading to expulsion of fetus. So this is the importance of retraction. So retraction is a unique property which leads to lower uterine segment formation, leads to cervical dilatation and effacement, which leads to progressive descent of presenting part leading to what? Expulsion of fetus. So what is the answer for this question, dear doctors? Yes, it is the right cornua which serves as a predominant pacemaker compared to the what? Left cornua. This is a false statement. And you all know, due to retraction, what will be there? Cervical effacement will be there. And what is the intensity of uterine contraction? It is measured in Montevideo units. How much it is? 200 to 225. Montevideo units. Look into this. What is this Montevideo units? It is the intensity. Please make a note of it. It is the intensity of uterine contraction. It is the intensity of uterine contraction. Okay. Now, it is nothing but average strength of contraction in millimeters of mercury into number of contractions in 10 minutes. Please make a note of it. It's the average strength of contraction in millimeters of mercury into number of contractions in 10 minutes. So, what is the normal number of contractions in 10 minutes? It is 3 to 5 contractions in 10 minutes. And what is the average strength of contraction in millimeters of mercury? Is nothing but peak uterine pressure minus basal uterine pressure. Means overall Montevideo units is nothing but pressure generated by all contractions in 10 minutes after subtracting basal pressure from peak uterine pressure. It is of about how much? 200 to 225 Montevideo units. It is, you got the point, doctor? It's a pressure generated by all uterine contractions in 10 minutes. It's a pressure generated by all uterine contractions in 10 minutes after subtracting baseline pressure from peak uterine pressure. What is the normal? It is 200 to 225 Montevideo units. I think this question is clear. Yes? Yes or no, dear doctors? Yes. Now, doctor, we will proceed to the next question. Now, a 16-year-old girl presented to gynecology OPD with history of not attained menarche. She is a 16 years she is not having menses. What is it? It is primary amenorrhea. What is the definition of primary amenorrhea, doctor? That is, in the absence of secondary sexual characteristics, no menses till 13 years, or in the presence of secondary sexual characteristics, no menses till 15 years. So it is a 13 years and 15 years contract. Is it clear? Yes. Yes. So now, doctor, what is the definition for primary amenorrhea? In the absence of secondary sexual characteristics, no menses till 13 years, or in the presence of secondary sexual characteristics, no menses till 15 years. Now, doctor, here this girl presents with primary amenorrhea. She is giving cyclical pain abdomen. Means monthly she is getting the pain. She has well developed breast and pubic hair. Means, so she has got secondary sexual characteristics. So then she has got cyclical pain abdomen. Yes. On local examination, there is bluish bulge noted in the vaginal orifice. Ultrasound reveals emetometra. Most likely diagnosis. What is the answer, doctor? What is the answer for this question? Dear doctors, what is the answer for this question? She has got primary amenorrhea, secondary sexual characteristic present, cyclical pain abdomen. On local examination, bluish bulge noted in the vaginal orifice. Ultrasound reveals emetometra. So only Dr. Olof is answering. What about others? What is the answer for this question? Dear doctors, yes, it is an imperforate hymen. Dear doctors, so it is a imperforate hymen. Dear doctor, in this imperforate hymen, understood, no doctor, the blood will start collecting and distending the vagina, which leads to what, doctor? Emetoculpus. Then which leads to expands to cervix, which is emetocervix. It also collects inside the uterus, which leads to what? Emetometra. You got the point, doctor? So now doctor, look into this. Yes, so most of them are answers are correct. It is the what? Imperforate hymen. Answer for this question is what? Imperforate hymen. Doctor, look into this. Whenever a girl presents with primary amenorrhea, yes, what is the first step? Dear doctor, what is the first step? It is nothing but examination of secondary sexual characteristics. Okay. Now, dear doctors, if secondary sexual characteristic present, what is the investigation of choice? If secondary sexual characteristic absent, what is the investigation of choice? Now, doctor, if secondary sexual characteristic present means definitely there is source of estrogen. Yes. So, investigation of choice is USG. So, why you will do USG, doctor? To rule out whether uterus present or absent. Now, dear doctors, if uterus is absent, what is the diagnosis? If uterus is present, what is the diagnosis? If uterus is absent, we have got two diagnoses. One is, that is Mullerian agenesis. One is Mullerian agenesis, which is also called as MRKH. Another one is, doctors, testicular feminization syndrome. testicular feminization syndrome, which is nothing but androgen insensitivity syndrome, which is nothing but what, doctor? Androgen insensitivity syndrome. So that is uterus absent, dear doctors, uterus absent but secondary sexual characteristic present. Now uterus present, so what is the diagnosis? That is cryptomenorrhea. Cryptomenorrhea. So what are the two DDs for cryptomenorrhea? One is imperforate hymen. Imperforate hymen. Another one, transverse vaginal septum. Imperforate hymen. Another one is transverse vaginal septum. And most common cause for cryptomenorrhea is imperforate hymen. Most common cause for cryptomenorrhea is what, doctor? Imperforate hymen. Is it clear? So whenever secondary sexual characteristic present, investigation of choice is USG. Why you will do USG, doctor? To rule out whether uterus present or absent. If uterus is absent, two diagnoses. One is Mullerian agenesis, which is nothing but MRKH, and also another one is testicular feminization syndrome, which is nothing but androgen insensitivity syndrome. And uterus present, always it is cryptomenorrhea, which is nothing but it is hidden menstruation. Cryptomenorrhea is nothing but what, doctor? Hidden menstruation. Yes, and what are the DDs for cryptomenorrhea? Imperforate hymen and transverse vaginal septum. Now, when secondary sexual characteristic absent, when secondary sexual characteristic absent means there is no source of estrogen. Means what is the investigation of choice? You should do FSH. What is the normal level of FSH? It is 5 to 20 international unit per liter. Investigation of choice is FSH, and normal level of FSH is how much? 5 to 20. Now, if FSH is, dear doctor, if FSH is increasing, yes, what is the cause? Or if FSH is decreasing, what is the cause? If FSH is increasing, it is the ovarian cause. FSH is increasing if it is the ovarian cause. If FSH is decreasing, it is hypothalamo-pituitary cause. Hypothalamo-pituitary cause. Please make a note of it. Hypothalamo-pituitary cause. If FSH is increasing, what is the cause? Ovarian cause. If FSH is decreasing, it is the hypothalamo-pituitary cause. I think this question is clear, doctor. Yes. So, and doctor, in imperforate hymen, the woman presents with classical bluish bulging tense membrane. Bluish bulging tense membrane. Bluish bulging tense membrane. It is always suggestive of what? Imperforate hymen. Imperforate hymen. And what is the treatment for imperforate hymen, dear doctors? It is a cruciate incision. Cruciate incision. Yes? Okay, now, dear doctors, so now we'll go to next question. All of the following are long-acting reversible contraceptive, that is LARC, except, what is the answer for this? Dear doctors, what is the answer for this? All of the following are LARC. What is LARC? Long-acting reversible contraceptive. What is this? So, doctor, what is the answer for this question? Which is not a LARC? Which is not a LARC? All of the following are LARC. Doctor, LARC includes two sets. One is IUCDs. Another one is implants. One is IUCDs, another one is implants. IUCD, that is LNG IUS and copper IUCD. Copper IUCD. LNG IUS is nothing but Mirena. And doctor, implants, that is Implanon. Implanon. So now doctor, among this, what is the answer? Yes, definitely the sterilization procedures is not a LARC. Definitely sterilization procedure is not a long-acting reversible contraceptive. Okay, doctors. So we have got two sets of LARC. One is IUCD, another one is implants. So in that IUCD, it can be LNG IUS, that is progesterone containing IUCD, that is levonorgestrel containing IUCD, and copper IUCD, and implants, that is Implanon. Okay. Yes. Now, dear doctors, Now answer this question. Levator ani muscle belongs to which level of D and C levels of vaginal support? This is a very high-heeled MCQ question, doctor. So it has recently appeared in the last year. So what is the answer for this? Levator ani muscle belongs to which level of D and C supports of vagina? So levator ani muscle belongs to which level of D and C supports of vagina? Doctor, we have got 3 levels. Dear doctors, I am going to write the line diagram. Look into this. I am going to write the line diagram for D and C supports of vagina. Yes. Look into this. D and C supports of vagina. This is the uterosacral ligament. Uterosacral and McEnroy's. Uterosacral and McEnroy's. And this is the anterior vaginal wall fascia. This is anterior vaginal wall fascia, and this is a posterior vaginal wall fascia. Dear doctor, anterior vaginal wall fascia, I will write here anterior vaginal wall fascia, nothing but arcus tendinous, fascia pelvis, arcus tendinous fascia pelvis, and posterior vaginal wall fascia, nothing but arcus tendinous rectovaginalis. So number 1 is arcus tendinous fascia pelvis. Number 2 is arcus tendinous rectovaginalis. So now here there will be what, doctor? Bladder, and there will be what? Rectum, and here there will be what? Bowel. Now doctor, so now, and this is the what, doctor? This is the levator ani muscle. This is a levator ani muscle. Now doctor, very simple. This is the level 1 D and C supports. So just remember this diagram for your exam. So this is the level 1 D and C supports, and this is the level 2 D and C supports, and this is the level 3 D and C supports. Level 3 means this is a levator ani muscle. Levator ani muscle. And what are the level 1 structures? It is the uterosacral and McEnroy's. Level 1 structures, it is a uterosacral and McEnroy's ligament. Please make a note of it. It is a uterosacral and what, doctor? McEnroy's. And what are the level 2 structure? These are the level 2 structures, and this is a level 3. You got the point, doctors? So now just look into this. I was telling you level 1. Level 1 includes 2 structures. One is uterosacral ligament, and another one McEnroy's ligament. Now imagine, doctor, I was telling you, whenever there is a level 1 defect, imagine there is defect at the uterosacral and McEnroy's. What will comes down? Bowel will comes down. That is enterocele. Level 1 defects leads to what, doctor? Enterocele or apical prolapse. That is apex of the vagina will prolapse, or walled prolapse. So this is the D and C supports. So level 1 is what, doctor? Uterosacral and McEnroy's, which leads to enterocele, apical prolapse and walled prolapse. Then level 2. Level 2, I told you 2 fascias, arcus tendinous fascia pelvis, arcus tendinous rectovaginalis. Now tell me, if there is arcus tendinous fascia pelvis defect, definitely there is cystocele. If there is arcus tendinous rectovaginalis defect, there is what, doctor? Rectocele. So doctor, so defects leads to cystocele and rectocele. Cystocele and what, doctor? Rectocele. This is a level 2 defects. Cystocele and rectocele, this is level 2 defects. Then level 3 defects. Level 3 defects, I told you, that is levator ani muscle, perineal body and perineal muscle. And definitely, dear doctor, level 3 defects leads to urethrocoele or gaping introitus, urethrocoele or gaping introitus? Yes. Okay. Now, so what is the answer for this question, dear doctors? So levator ani muscle belongs to what Delancey support? Definitely it is level 3 Delancey support. Level 3 Delancey support. No, rectocele is not level 3. Always rectocele is always level 2. Is it clear, doctor? Rectocele is always level 2. Means level 3 is not rectocele. Level 3 is definitely it is urothrocele or gaping introitus. So that is definitely level 2. It is nothing but paravaginal defects. Very good. It is a paravaginal tissue. Paravaginal defects or paravaginal tissue. I think this is clear. Yes. Okay. So doctor, I request everyone to know the levels of Delancey supports of vagina. It is an upcoming topic. So that's why I made very simple with this line diagram, because you can't mug up the levels of Delancey supports. But with the line diagram, you can easily remember. You can easily remember. Okay. Yes. Now, a 85-year-old lady presented to OPD with a complete procedentia. She has difficulty in walking and complaints of urinary incontinence. She recently underwent coronary bypass surgery. What is the best management for her? What is the answer for this question, dear doctors? What's the answer? Yes, waiting for your answers. So what is the answer for this? A 85-year-old lady presented to OPD with a complete procedentia. She underwent coronary bypass. Definitely it is a pessary insertion. Pessary insertion. So a woman who is unfit for surgery, do not want surgery, avoiding surgery, or prolapse in pregnancy or postpartum, or to manage for healing of the decubitus ulcer. These are the 5 golden indications for pessary. Please make a note of it. So 5 golden indications, that is unfit for surgery. Unfit for surgery. Welcome Dr. Shivam Bateja. Thank you. So now, so what are all the indications for pessary? That is unfit for surgery. Unfit means if there is uncontrolled diabetes or hypertension, definitely will go for pessary. Then do not want surgery. Patient is not interested for surgery. Do not want surgery. Or patient is avoiding for surgery. If there is uncontrolled diabetes, she is put on insulin so that the sugar value should come back to normal. That is avoiding for surgery. Avoiding for surgery. Then prolapse. Dear doctor, prolapse during pregnancy and postpartum. Prolapse during pregnancy and postpartum, or during healing of decubitus ulcer. Healing of decubitus ulcer. Dear doctor, these are the 5 golden indications. Understood, doctor? Unfit for surgery, avoiding surgery, do not want surgery, prolapse during pregnancy and postpartum, and what during healing of decubitus ulcer. Definitely we will go for what? Pessary. Now doctor, so pessary, we have got 2 varieties of pessary. One is supporting pessary. Please make a note of it. One is supporting pessary. Another one is space occupying pessary. Space occupying pessary. Space occupying pessary. Now doctor, most common supporting pessary is ring pessary. Ring pessary. What are the other supporting pessary? Yes, arch pessary, Gehring pessary. Yes. So now doctor, the supporting pessary, especially in stage 1 and 2 prolapse. Stage 1 and 2 prolapse, you are going to use supporting pessary. Now space occupying pessary. What are the space occupying pessary? Yes, that is Gilhorn, Donut and Q pessary. And indications, it is a stage 3 and 4 prolapse. Stage 3 and 4 prolapse. You got the point, doctor? We have got 2 varieties. One is supporting pessary. Yes, nothing but ring pessary. Ring pessary is the most common supporting pessary. And what are the other pessaries? Space occupying pessary. Space occupying pessary. And so how to follow up this? Dear doctors, how to follow up? Doctor, within 1 week of insertion, definitely we have to follow up. Within 1 week of insertion, we have to follow up. After 1 week of insertion, we have to go for 3 monthly follow up. 3 monthly follow up. Please make a note of it. Within 1 week of insertion, yes, first follow up. After that, 3 monthly follow up. During the 3 monthly follow up, we'll ask for foul smelling vaginal discharge, any pain, or vaginal bleeding. How to clean? We'll clean with hot water or autoclaving. We'll clean with hot water or autoclaving. Understood, doctor? So this is about the golden points on pessary. Yes. What is the third name? That is donut pessary. Donut. Gehrang, Gilhorn, donut. You got a point, okay? Ring pessary, arch pessary, Gehrang pessary. These are all the supporting pessaries. These are all the supporting pessary, and space occupying Gilhorn, donut and cube. Cube pessary. Donut and cube pessary. Is it clear? Yes. Is it clear, doctor? Is this question is clear? Yes. Now, doctor, we proceed to the next question. Yes. Very nice question. 2-cell 2 gonadotrophin theory of follicular phase, estrogen production, it is given. Now, doctor, look into this. What is ABCD? Answer for this question. Very nice question. Dear doctor, this is a repeat question from INI-CET. It is a 2-cell 2 gonadotrophin theory of follicular phase and estrogen production. What is A? What is B? What is C? What is D? So there, what A is granulosa cells, or theca cells, or estrogen or progesterone? Please answer this question very nicely prepared. What is the answer for this question? 2-cell 2 gonadotrophin steroidogenesis. That is in the follicular phase for estrogen production. Try for this question. Now here is a 2-cell 2 gonadotrophin steroidogenesis. You all know from hypothalamus GnRH is released. Now doctor, this GnRH acts on anterior pituitary to release LH and FSH. Now LH acts on theca cells. That is a $1 million MCQ. You got the point, doctor? LH acts on theca cells. FSH acts on granulosa cells. Means theca cells has got LH receptors. Granulosa cells has got FSH receptors. Now doctors, now theca cells, that is it has got cytochrome P17 activity. Please make a note of it. Theca cells has got cytochrome P17 activity, and granulosa cells has got aromatase activity. These are the two golden MCQs. Theca cells means LH receptors. Granulosa cells means FSH receptors. So theca cells means it is the cytochrome P17 activity. Granulosa cells means it is the aromatase activity. Now doctor, theca cells, it produces two androgens. One is androstenedione, another one is testosterone. Testosterone. Now doctor, so androgen production, please make a note of it. Androgen production means definitely it is theca cells. Androgen production means definitely it is theca cells. Now doctor, produced androgens diffuses into granulosa cells. It is converted to estrogen. Means androgen to estrogen. Means estrogen production means it is always granulosa cells. Means androstenedione is converted into E1 form of estrogen, and testosterone is converted to E2 form of estrogen. So E1 means estrone, E2 means estradiol. Estradiol means androgen to estrogen. What is the enzyme, doctors? What is the enzyme? Aromatase. Aromatase. Understood, doctor? So now doctor, so granulosa cells means definitely estrogen production. Definitely estrogen production. Yes, and theca cells means definitely it is androgen production. Now come back to this question. Now option A. What is option A? FSH receptors means option A is definitely what it is? Granulosa. Yes. LH means, B means what it is? Theca cells. Theca cells. Yes. Now doctor, look into this. So now theca cells produces what? Androgens. Theca cells produces what? Androgens. Theca cells produces what? Androgens. Now, so these androgens undergoes aromatization to produce what? Estrogen. So now A is granulosa cells, definitely. B is theca cells. Yes. So what about C, doctor? Definitely C is estrogen. C is estrogen, and D is what? Androgen. So which is the option? So what is the option? Dear doctors, which option? Option D. So A is granulosa, B is theca, C is estrogen, D is androgen. That is option D. Is it clear? This question is clear, doctor? So take home message. Theca cells means LH receptors, granular cells means FSH receptors. So theca cells means androgen production, granular cells means estrogen production. Understood, doctor? Theca cells means cytochrome P17 activity, granular cells means aromatase activity. I think this is very clear. No doubt? Yes. So we can proceed with option? Yes. Now doctors, now we'll proceed to next question. Yes, very nice question. 25-year-old presented with heavy menstrual bleeding with dysmenorrhea. On bimanual examination, uterus is 14 to 16 week size, irregularly enlarged, and mass is felt through the anterior fornix. On ultrasound, hyperechoic mass is seen on the subserosal layer of the uterus, extending more than 50% of what? Intramural layer. What Figo type of fibroid is this? Now doctor, before coming back to this question, we have to know the Figo classification of the fibra. So now doctor, look into this. Before this, doctor, as per Figo, look into this, we have got submucosal. Please make a note. We have got submucosal fibroid, that is SM, and others. Now doctor, submucosal, we are given a score of 0, 1, 2. 0, 1, 2 is submucosal. Others means we are given a score for intramural fibroid. Please make it, we are given a score of, dear doctors, we are given a score of intramural, that is 3, 4, intramural 3, 4, then 5, 6, 7, it is subserosal, and 8 is others. 8 is what doctor? Others. Now doctor, for submucosal fibroid, we are given a score of 0, 1, 2, 3, 4 is definitely intramural, 5, 6, 7 is subserosal, 8 is others. Now doctor, what is this type 0? Type 0 is submucosal, that is pedunculated, doctor, it is pedunculated submucosal, which can be removed easily via hysteroscopy. So completely lies within the uterine cavity. Type 0, it is pedunculated submucosal. Type 1, that is less than 50% intramural, means doctor, more fibroid is within the uterine cavity. More fibroid is within the uterine cavity, less fibroid in the intramural, that is less than 50% intramural. So type 1 also can be removed hysteroscopically. Type 2, more than or equal to 50% intramural. Type 2, more than or equal to 50% intramural, means more fibroid in the intramural, less fibroid in the uterine cavity, which is not removed via hysteroscopy. That is type 0, 1 and 2. So type 0 is what doctor? Completely lies within the uterine cavity, that is pedunculated submucosal. Type 1 is more fibroid lies in the uterine cavity, less fibroid is intramural, that is less than 50% intramural. Less than 50% intramural. So type 2 is more than or equal to 50% intramural. Now come to type 3, it is contact endometrium, means it is touching the endometrium. That is nothing but contact endometrium, 100% intramural. Contact endometrium, 100% intramural. And type 4, it is intramural. Type 4 is intramural. So this is about submucosal and what doctor? Intramural fibroid. Now come to subserosal. Type 5, more fibroid in the intramural lesion, less fibroid in the peritoneum, means take down doctor, more than or equal to 50% intramural, that is subserosal. More than or equal to 50% intramural, that is what doctor? Subserosal. You got the point doctor? Then less than 50% intramural subserosal, that is type 6. And type 7 is pedunculated subserosal. Pedunculated subserosal. So subserosal has given a number of 5, 6, 7. 5 means more fibroid in the mural region, less fibroid in the peritoneal cavity, means more than or equal to 50%. More than or equal to 50% intramural, that is 5. Less than 50% intramural, 6. Pedunculated subserosal, it is 7. It is 7. Now doctor, come to 8, that is nothing but others. Others means it is cervical fibroid. Others means it is cervical fibroid. This FIGO classification is clear. You should know we are given 0, 1, 2 score for submucosal, 3, 4 for intramural, 5, 6, 7 for what? It is subserosal. And 8 is others. Others means what it is? Cervical fibroid. 8 is others, that is cervical fibroid. Cervical fibroid. Is it clear? And there is another one fibroid, that is hybrid leiomyomas. Hybrid leiomyomas. It is nothing but fibroids extending from endometrium to subserosa. That is endometrium to serosa. So hybrid leiomyomas nothing but endometrium to serosa. Means we are given two numbers separated by hyphen. 2 represents endometrium, 5 represents serosa. This is hybrid leiomyomas. This is hybrid leiomyomas. I think this is clear. Now come back to the question. On ultrasound, hyperechoic mass is seen in the subserosal layer of the uterus extending more than 50% intramural. So what is it is? Type 5. Definitely it is type 5. Definitely it is type 5. I think this question is clear. This is also a repeat question. Okay, now answer this. Which of the following are protective against endometrial cancer? So what are the protective factors? What are the risk factors? Answer this question. What are the protective factors? What are the risk factors? Dear doctors, what are the protective factors? What are the risk factors? So now, dear doctors, so risk factors, if it is, there is excess estrogen exposure, either it can be endogenous or exogenous. What are the endogenous conditions? Early menarche. Take down early menarche, late menopause. Early menarche, late menopause, that is a one thing. Nulliparous, obesity, chronic anovulation conditions like PCOS, and even estrogenic tumor. What is that estrogenic tumor, doctors? Granulosa cell tumor. Please make a note of it. Granulosa cell tumor. Estrogenic tumor. Please make it, that is granulosa cell tumor. This is all the endogenous estrogen exposure. Exogenous, if the patient is on estrogen hormonal replacement therapy, and if the patient is on tamoxifen. Dear doctor, whenever the patient is on tamoxifen, what has to be measured? It is the endometrial thickness to be measured. When the patient is on tamoxifen, what has to be measured? It is the endometrial thickness to be measured. So these are all the unopposed estrogen conditions. Please make a note of it. Now, if there is diabetes plus hypertension, once again risk factor. Hereditary, yes, what hereditary? If there is hereditary of, that is Lynch 2, nothing but HNPCC2, definitely it's a risk factor for endometrial CA. And family history of endometrial CA, yes, breast CA, endometrial CA, breast CA, colon cancer, yes. So these are all the family history, and there is germline mutations of P10, P53, BRCA1. So these are all the risk factors. Please make a note of it. These are all the risk factors for what? Endometrial CA. These are all the risk factors for endometrial CA. And what are the components of corpus cancer syndrome? That is diabetes, hypertension, obesity. Yes, even there is a family history of ovarian cancer also leads to what, doctor? Endometrial CA. So diabetes, hypertension, obesity and endometrial CA constitutes what? Corpus cancer syndrome. You got the point, doctor? So these are all the risk factors. So with these risk factors, you should also know protective factors. Protective factors, yes, progesterones, definitely protective factors. Progesterones, yes. Nulliparous is a risk factor. Multiparity is a protective factor. Multiparity, breastfeeding, lactation or pregnancy. Take them, doctor. Yes. So multiparity, breastfeeding, pregnancy. So these are all the protective factors. Then early menopause. Late menopause is a risk factor. Early menopause is a protective factor. Then smoking, Smoking, regular exercise. Obesity is a risk factor. Regular exercise is a protective factor. Regular exercise is a protective factor. Then OCPs is also what, doctor? Protective factor. This is a list of risk factors and protective factors. Come back to the question. Answer, which of the following are protective against endometrial cancer? Smoking, definitely it's a protective factor. Multiparity is a protective factor. Late menopause is a risk factor. HRT is a risk factor. OCPs is a protective factor. So it is 1, 2 and 5. That is option C. Option C. Yes, I think this question is clear. Okay, now come back to this. A 28-year-old with history of IUCD insertion 3 years back came with complaints of not feeling the thread. On perspiculum examination, the thread is not visible and ultrasound shows IUCD embedded in the myometrium. What is the next line of management? What's the answer for this question, dear doctors? So she was inserted IUCD 3 years back. On perspicular examination, the thread is not visible. Ultrasound shows IUCD embedded in the myometrium. What is the next line of management? What's the management? What is the next line of management? Now, doctor, whenever if you are seeing missed IUCD, we have got 5 options. 1, if the thread is coiled inside, please make a note of it. If the thread coiled inside, that could be the option. Or if thread detached and fallen out. Thread detached and fallen out, or IUCD itself expelled. IUCD itself expelled, or IUCD perforated. IUCD perforated, or IUCD with pregnancy. Please make a note of IUCD with pregnancy. IUCD with pregnancy. So these are all the 5 options. 1, thread coiled inside, or thread detached and fallen out, or IUCD itself is expelled, or IUCD perforated, or IUCD with pregnancy. That's why the first investigation of choice is always USG, that is TVS. That is the first investigation of choice. Second investigation of choice is, doctor, second investigation of choice is, that is X-ray with uterine sound. X-ray with uterine sound, or X-ray with new IUCD insertion. New IUCD insertion. Take down, doctor. So first investigation of choice is what, doctor? It is USG. Second investigation of choice is X-ray with uterine sound or X-ray with new IUCD insertion. Doctor, this uterine sound or new IUCD will guide the position of old IUCD. Will guide the position of old IUCD. Yes? Yes. Now, I told you second investigation of choice is X-ray with uterine sound or X-ray with new IUCD. Now, whenever the thread is coiled inside or thread detached and expelled, what do you want to do? Yes, we can continue with IUCD. If the patient wants to continue, definitely we can continue with IUCD. We can continue with IUCD, or we can remove the IUCD via artery forceps. That is, here uterine sound, dear doctor, uterine sound inserted into uterine cavity. Uterine sound inserted into uterine cavity to probe IUCD, and can be removed. Can be removed by what, doctor? Can be removed by what? Artery forceps. Can be removed by artery forceps. So understood, doctor? If the thread is coiled or if the thread is torn and expelled, either we can go for continue with IUCD, or uterine sound inserted into uterine cavity to probe the IUCD and can be removed by artery forceps. If IUCD is embedded in the myometrium, it can be removed hysteroscopically. If IUCD perforated completely, into peritoneal cavity, go for laparotomy. If it is partly in the uterus, partly in the peritoneum, we can go for hysterolaparoscopy. But preferred is laparoscopy. but preferred is laparoscopy. You got the point, doctor? Understood? Yes. So whenever IUCD embedded in the myometrium, definitely go for hysteroscopical removal. IUCD perforated, completely go for laparotomy. Partly in the peritoneum, partly in the uterus, go for hysterolaparoscopy. Hysterolaparoscopy. What is the answer for this question? So IUCD embedded in the myometrium, definitely go for hysteroscopic removal. Definitely go for what, doctor? Hysteroscopic removal. I think this question is clear. Yes. Now answer this question. According to ACOG criteria, all of the following conditions require endometrial HPE assessment except. This is also a repeat question of INI-CET. Yes. So what is according to ACOG criteria? What are all women require endometrial biopsy? Means all of the following are women who require endometrial biopsy except, means which is not the indication for endometrial biopsy according to ACOG criteria or according to FOXY, because definitely FOXY follows ACOG. What is the answer for this question? What's the answer for this question? Yes. Doctor, look into this. According to FOXY, what are the indications? That is AUB in women. AUB in women more than 40 years. Definitely AUB in women more than 40 years definitely requires endometrial biopsy. Then AUB in women less than 40 years with associated risk factors. With associated risk factors. Please make a note of it. AUB in women more than 40 years definitely requires endometrial assessment. AUB in women less than 40 years with associated risk factors. What are the associated risk factors? If she is PCOS or obesity, or if she is on tamoxifen therapy, or endometrial thickness more than 12 mm in perimenopausal women, endometrial thickness more than 12 mm in perimenopausal women, and if there is family history of hereditary endometrial ovarian breast CA, yes, understood, doctors? Then persistent AUB with failed medical management, persistent AUB with failed medical management, and post-menopausal bleeding with endometrial thickness more than 4 mm. So these are all the FOXY or ACOG recommended indications for endometrial biopsy. Please make a note of it. Understood? So AUB in women more than 40 years. If the woman is less than 40 years, we will search for risk factors like PCOS, yes, obesity, tamoxifen therapy. I told you whenever the woman is on tamoxifen, definitely endometrial thickness to be monitored. And endometrial thickness more than 12 mm in perimenopausal women. Endometrial thickness more than 12 mm in perimenopausal women, and family history of hereditary ovarian, endometrial and breast CA. And doctor, persistent AUB with failed medical management. Persistent AUB with failed medical management and post-menopausal bleeding with endometrial thickness more than 4 mm. Post-menopausal bleeding with endometrial thickness more than 4 mm. These are all the indications. Now, what is the answer for this? All women more than 40 years with AUB definitely indication. Unresponsive to medical management indication. All women less than 40 years. No, it is not an indication. It is not an indication. And PCOS with AUB definitely indication. Yes, it is not 40 years. No, it is not 40 years. It is 40 years. It is not 45 years, doctor. It is 40 years. So, doctor, according to ACOG, it is 40 years. And so, some books gives also 45 years, but always go for 40 years. Is it clear? Okay. Now look into this. A patient develops PPH after delivery of placenta, and patient is a known case of asthma. Which of the following drug is contraindicated in treatment of PPH? Whenever a patient is a known case of asthmatic, what uterotonic is contraindicated? Dear doctor, whenever the patient is a known case of asthma, what uterotonic is contraindicated? Definitely it is the carboprost, which is nothing but 15-methyl PGF2 alpha. 15-methyl PGF2 alpha. You got the point, doctors? Yes. Now, doctor, you all know. So, first line uterotonic is oxytocin. It is WHO recommended. I am telling you, WHO recommended. First line uterotonic is what, doctor? Oxytocin. What is the start dose? Definitely 10 units. 10 units IM or IV infusion. Never IV bolus. Never IV bolus. IM or IV infusion. Maximum doses 20 to 40 units and 500 ml of crystalloid, that is normal saline or ringer lactate. Please make a note of it. Maximum doses, that is 20 to 40 units in 500 ml of crystalloid, nothing but normal saline or ringer lactate. Understood, doctor? So now never infuse with dextrose. That is the first point. Why? If you infuse with dextrose, never infuse with dextrose, it causes what, doctor? Water intoxication and hyponatremia, that is dilutional hyponatremia. That is the one thing. Never infuse with what, doctor? Never infuse with dextrose. That is the one thing. Never IV bolus. Why? It causes sudden hypotension. You got the point, doctor? These are all the important contraindications and side effects. Contraindication, never infuse with dextrose, never IV bolus. What all the side effects, doctor? What all the side effects? Yes, one is water intoxication and another one is hyponatremia, another one is sudden hypotension and cardiac arrest. So these are all the contraindications and side effects of what, doctor? Oxytocin. This is a preferred uterotonic or first line uterotonic. This is a preferred uterotonic or first line uterotonic. Please make a note of it. So I told you, so start dose 10 units IM or IV infusion, never IV bolus. It causes sudden hypotension. And maximum dose 20 to 40 units in 500 ml of crystalloid solution, that is normal saline or ringer lactate. Never infuse with, doctor, never infuse with what? Dextrose, because it causes water intoxication and hyponatremia. Now second line is ergot alkaloids. What are the ergot alkaloids? That is ergometrin or methergine. That is ergot alkaloids. It can be given at a dose of 0.2 mg IM or IV. 0.2 mg IM or IV. What is the side effect? Doctor, what is the side effect of this ergot alkaloid? It causes, yes, nausea, vomiting and hypertension. It causes hypertension. Contraindications, yes, if mother is having organic heart disease, definitely we will withhold giving ergot alkaloid. If mother is RH negative pregnancy, or if mother is hypertensive, I told you it causes hypertension, definitely if mother is preeclampsia or hypertensive, definitely will withhold giving ergot alkaloid. And following delivery of first twin. These are all the contraindications of ergot alkaloids. These are the contraindications. So first line, second line. Third line is prostaglandins. That is 15-methyl PGF2 alpha, nothing but carboprost, which is also called as dinoprost or imabate or prostadine. And what is the start dose? Doctor, start dose is 250 microgram intramuscular. Start dose 250 microgram intramuscular. Maximum doses 8 doses. That is 250 microgram every 15 to 19 minutes for 8 doses. Nothing but 8 into 250. That is nothing but 2000 microgram or 2 mg. 2000 microgram or 2 mg. Contraindication, definitely in bronchial asthma patients, we won't give carboprost. What are the other? If there is any liver disease or renal disease, or if there is any cardiac disease, definitely we won't go for what? Carboprost. And side effects, take down, doctor. Side effect, diarrhea is the most common side effect. Take down, doctor. Diarrhea is a most common side effect, and other side effects: fever, tachycardia, and even vomiting. Yes. So now come to other prostaglandin, that is PGE1, that is nothing but misoprostol, which can be given at a dose of 800 to 1000 microgram per rectally. It can also be given orally or sublingually. But Government of India recommends, dear doctor, Government of India recommends 800 microgram orally for treatment of PPH. 800 microgram orally for treatment of PPH. And what is the contraindication? Previous C-section is a contraindication, and side effect, that is fever, dose related hyperthermia, fever and tachycardia. So these are all the few golden points on uterotonics. Is it clear? Dear doctors, is it clear? Yes? Any doubt? So when a patient is a known case of asthma, what is to be avoided? It is a carboprost. Okay, doctors, now answer this question. Very nice question. Look into this. A 30-year-old primary gravida visits to routine ANC OPD with complaints of abnormal vaginal bleeding at 10 weeks of gestation. She is 10 weeks pregnant. USG reveals positive intrauterine pregnancy. On further workup with cytology reveals, yes, adenocarcinoma in situ. Biopsy confirms invasive adenocarcinoma. What is the next step? That is management of cancer cervix in pregnancy. That is one thing the question here is. So she is a 30-year-old primary gravida, visits to routine ANC OPD with complaints of abnormal bleeding PV at 10 weeks of gestation. USG reveals positive intrauterine pregnancy. On further workup with cytology reveals adenocarcinoma in situ. Biopsy confirms invasive carcinoma. What is the next step? What is the answer for this question? Dear doctors, what is the answer for this question? So classical cesarean section followed by radical hysterectomy at a term, medical termination of pregnancy, conization early. So conization early in the second trimester, chemoradiation. What is the answer for this question? Yes, it's so carcinoma cervix management. Dear doctor, look into this. When you go to management of cancer cervix in non-pregnant, you all know, dear doctor, you all know all stages of cancer cervixes. I am telling you non-pregnant. I will come back to pregnancy state. First, just 2 minutes we will discuss cancer cervix management in non-pregnant. That is, all stages of cancer cervix is radiosensitive. But before giving radiation, understood, no, chemo agent is given so that tumor cells become very receptive for radiation. What is that called as? Chemoradiation. Means all stages we can give chemoradiation. But till what stage we can operate? Till stage 2A1 we can operate. And any stage with tumor size more than or equal to 4 centimeters. What are the stages with tumor size more than or equal to 4 centimeters? 1B3 and 2A2, definitely chemoradiation, no surgery. Means final take home message, what are all the operable stages? Dear doctor, what are all the operable stages and what are all the inoperable stages? What are all the operable stages and what are all the inoperable stages? Now, dear doctors, operable stages, I told you 1A1 is operable, 1A2 is operable, 1B1 is operable, 1B2 is operable, but 1B3 is not operable. Because why 1B3 is not operable? Because it is more than or equal to 4 centimeters. I told you any stage with tumor size more than or equal to 4 centimeters, definitely you have to go for chemoradiation, no surgery. Then, dear doctor, 2A1 is operable. But 2A2 is not operable because it is once again more than or equal to 4 centimeters, and 2B, 3 and 4 definitely inoperable. Means till stage 2A1 we can operate. Please make a note of it. Till stage 2A1 we can operate. Beyond stage 2A1, that is 2A2, 2B, 3 and 4, definitely inoperable. Chemoradiation. This is non-pregnant state. Come to pregnancy, same thing is applicable. Doctor, in pregnancy, just we will divide into less than 20 weeks. Yes, more than 34 weeks and between 20 to 34 weeks. Like this we will divide. You got the point, doctor? Less than 20 weeks, more than 34 weeks and 20 to 34 weeks. You got the point, doctor? So same way I divided here like this, less than 20 weeks, more than 34 weeks, yes, then 20 to 34 weeks. Doctor, in 1A1, 1A2, whether it is a less than 20 or more than 34 or between 20 to 34, definitely we have to go for conization. Definitely we have to go for what, doctor? 1A1 or 1A2, whether it is less than 20 weeks or more than 34 weeks or between 20 to 34 weeks, we have to go for conization. We have to go for what, doctor? Conization. Take down. We have to go for conization. Yes? Yes. Now come to 1B1, 1B2, 1B3, 2A1, 2A2, 2B3 and 4. 1B1, definitely it is operable. So like non-pregnant state. Like we will treat like non-pregnant stage. Take down, doctor, look into this one thing, take down here. So less than 20 weeks, we will treat like non-pregnant. Just for easy sake, I am telling, less than 20 weeks, we will treat like, dear doctors, less than 20 weeks, we will treat like non-pregnant. More than 34 weeks, if it is salvageable baby. More than 34 weeks, if it is salvageable baby, yes, we will deliver by, doctor, we will deliver by classical cesarean, golden point, we will deliver by classical cesarean section and treat like non-pregnant state. Treat like non-pregnant state. You got the point, dear doctors? So salvageable baby, we will deliver by classical cesarean and treat like non-pregnant state. Yes, yes. Like this, we'll come back to less than 20 weeks. Same, like radical hysterectomy with pelvic lymph node dissection. Yes, pelvic lymph node dissection. That is with baby in utero. We'll do with baby in utero. Yes, definitely 1B1. Same like non-pregnant, that is radical hysterectomy with pelvic lymph node dissection. Here also 1B2 also same, radical hysterectomy with pelvic lymph node dissection with baby in utero. 1B3 not operable. Yes, we'll go for what, doctor? Chemo-RT. 2A1 operable, that is radical hysterectomy with pelvic lymph node dissection. And 2A2 it is inoperable, that is chemo-RT. Yes. Yes, is it clear, doctor? Yes, and this one more than 34 weeks we will deliver. We will deliver by what, doctor? Classical cesarean section and treat like what, doctor? Non-pregnant state. Treat like non-pregnant state. You got the point, doctor? Yes, between 20 to 34, doctor, between 20 to 34, that is, take down 1B1, yes, 1B1, 1B2 and 2A1, yes. Doctor, between 20 to 34 weeks, that is 1B1, yes, 1B2 and 2A1, yes, will give neoadjuvant chemo, prolong pregnancy up to 34 weeks. At 34 weeks, deliver by classical cesarean section and do radical surgery. That is for 1B1, 1B2 and 2A1. What about 1B3, 2A2, 2B and 3 and 4? 3 and 4 we will deliver by hysterotomy. Take down, doctor, we will deliver by what, doctor? Hysterotomy. Is it clear? So, doctor, if in 1B1, 1B2 will give neoadjuvant chemotherapy, prolonged pregnancy up to 34 weeks. At 34 weeks, yes, deliver by classical cesarean and do radical surgery. Yes, then in 1B2, yes, definitely you will deliver by hysterotomy followed by radical surgery. So this is the management of cancer cervix in pregnancy. So this table definitely very easy to remember for your exam. Please look into this table. Understood, doctor? So just it is like non-pregnant state only. Okay, doctors. So now we'll come back to the next question. A 24-year-old gravid at 34 weeks visits to labor casualty with complaint of nausea, yellowish discoloration of eyes and urine since 5 days. Since 5 days there is yellowish discoloration of eyes and urine. On examination, serum bilirubin is increased. Yes, hemoglobin is decreased. Platelet count is decreased. Please make it on examination. Serum bilirubin is increased. Hemoglobin is decreased. Platelet count is decreased. RBS, random blood sugar is decreased. Yes, liver enzymes is elevated. Peripheral smear is normal. What's the answer for this? Definitely, if random blood sugar is decreased, yes, means something gluconeogenesis affected, means something liver pathology. Definitely it is acute fatty liver of pregnancy. You got the point, doctor? Few golden points on acute fatty liver of pregnancy, more common in male fetus in third trimester due to defect in LCHAD pathway. What is LCHAD? Long chain 3-hydroxyacyl CoA dehydrogenase pathway. You got the point, doctor? So means it is a liver pathology. It is a liver pathology. That's why it has got all clotting factors will be decreased in AFLP. That means decreased fibrinogen. Yes. So decreased platelet count, decreased cholesterol, decreased fibrinogen, decreased platelet, and prolonged what, doctor? Prothrombin time, clotting time, and APTT. Yes, and liver enzymes will be within the range of 200 to 800. You got the point, doctor? So very important golden differences. Doctor, very important golden differences between acute fatty liver pregnancy and HELLP syndrome. You got the point, doctor? Acute fatty liver pregnancy and HELLP syndrome. What are the main differences? Please make a note of it. Acute fatty liver and HELLP syndrome, main differences. So now, doctor, acute fatty liver pregnancy, here serum fibrinogen level, it is a clotting factor. Serum fibrinogen level will be decreased, hypofibrinogenemia. Here serum fibrinogen level will be normal. Yes, and your glucose level is decreased. Your glucose level will be normal, and your PT, APTT, yes, prolonged. Your PT, APTT will be normal. PT, APTT will be normal. Yes, these are the few golden differences between acute fatty liver pregnancy and HELLP syndrome. I think you are all happy with this. Yes. So here platelet count is decreased, RBS is decreased. Doctor, HELLP syndrome and AFLP, you know how to difference. And doctor, in obstetric cholestasis, doctor, they will mention about serum bile acids or serum bile salts. In acute hepatitis, yes, liver enzymes will be in the range of thousands. In acute hepatitis, liver enzymes will be in the range of what? Thousands. I think this question is clear. Yes, I think, doctor, so you should make familiar with the carcinoma cervix management. That is a very high yield MCQ, what I want to discuss in this session. I think definitely this session will help you in solving the questions in INI-CET. I think you are all happy with this session, dear doctors. Dear doctors, you are all happy with this session? Yes? Yes. Please read, revise. Anyway, doctors, all the best for even INI-CET. Thank you, doctors.